So I did want to start off with sort of some of the basics around opioid use disorder treatment, with some focus on the utilization of buprenorphine. But I'll move fairly quickly through that because really want to spend a good portion of the time that we have together in some discussion around the new guidance, any other questions that we might have time for. If you're someone who's been thinking about engaging in this practice and maybe this announcement has prompted more interest and things along those lines. So won't belabor points around the importance of opioid use disorder. I'm sure those of you with this interest on this call are aware that though some guidelines and some policies around prescription opioids have led to reductions in that supply in the community, opioid overdose mortality continues to rise at an alarming rate due to fentanyl and analogs, and not just in the heroin supply. I mean, fentanyl itself is being marketed, and it's landing in the illicit stimulant supply as well, and in counterfeit tablets on the street. So it's really become rife in the illicit supply here. And as someone develops problems controlling their use of opioid, develops an opioid use disorder, medication really is first line in the treatment of that issue. Relapse rates are so high, and particularly with fentanyl in the illicit supply, risk for death is so high that prescribing medication to assist them as they enter recovery is really, a key piece. And I'll be talking a little bit more in particular about that briefly before we get to discussion. And then I do want to spend a little bit of time talking about the new requirements, the reduced requirements for obtaining an X waiver to prescribe buprenorphine in offices for opioid use disorder that may allow for some expanded practice and may allow and may sort of make you or colleagues in your practices feel a little more encouraged to engage in the practice, which during my time I found to be really, really rewarding. I'm not going to belabor the point around what we're talking about when we're talking about use disorder, other than to make you aware, if you're not, that this is really sort of the diagnostic standard in the area, the Diagnostic and Statistical Manual of Mental Disorders, currently in its 5th edition, which tells us that a use disorder involves maladaptive use that results in repetitive consequences in 2 or more of these areas over the course of the prior 12 months, where you see the first 2 being indicators of physical dependence, tolerance, and withdrawal, which I'm sure you have some familiarity, and the remainder being more indicators that the individual's use has evolved to compulsive use and a loss of control over that use where treatment is indicated. I also point out that terminology, use disorder, to draw attention to the fact that there are some terms in this 5th edition of the DSM that have gone away. Abuse is no longer a clinical diagnosis, and dependence doesn't carry the same definition that it had previously. Still some utility in communicating clinically around physical dependence and the like, but they're no longer formal diagnoses the way use disorder is in the DSM-5. And so given that, I mean, I pretty frequently, as I collaborate with other services, see the term sort of abuse thrown out. And I think the context is pretty typically they're trying to indicate if the individual is using something recreationally for purposes of intoxication. But that term, again, has sort of lost a little bit of clarity with this transition. And for my own mind, I find misuse, which hasn't really been used, in a clinical way in DSM, perhaps a little more useful along those lines and accurate. So I already alluded to this when we're talking about opioid use disorder. Particularly moderate severe pharmacotherapy is really part of any sort of first line plan around addressing it. And these are the agents that are currently FDA approved by way of maintenance and perhaps in some cases detoxification formulations, though there are others. in that latter category, with the opioids or opioid agonists being methadone and the buprenorphine preparations. And there's also an FDA approval of opioid antagonist, naltrexone. The oral formulation, a tablet taken once daily, hasn't borne out well in terms of effectiveness, and so its use in this situation is discouraged. But the monthly injectable formulation does have some findings related to reduction in use, reduction in craving, though we don't have the compelling findings around monthly naltrexone that we have with methadone and buprenorphine by way of actual mortality reduction and longer-term improvements in functional status. And this is just a diagrammatic representation of what we're talking about when we're talking about sort of evolution around use disorder and landing on agonist therapy, where with initial use, an individual will experience sort of this euphoria with cycles, with repeated use, moving between euphoria and feeling normal and looking for that positively reinforcing set of feelings, the euphoria. But as the use continues and evolves, the ongoing use really becomes an effort to avoid the horribly unpleasant sensations that go along with opioid withdrawal. And so with the implementation of medication for opioid use disorder actually being the more current parlance rather than medication-assisted therapy, with methadone or buprenorphine, there's this more steady, stable opioid level that persists throughout 24 hours and better allows the individual to function, to stay away from illicit use, also known to reduce proportion of income derived from criminal behavior, bloodborne virus transmission, and a host of other positive impacts. And normally, prior to 2000, it was on the whole not explicitly legal to prescribe a controlled substance for purposes of detoxifying or maintaining an individual for the use disorder indication. And buprenorphine is still an opioid. It's a partial opioid agonist. I'll be talking about it in a little bit, but it's still a controlled substance, Schedule III. But this legislation in 2000 allowed for its use as it became FDA approved for the treatment of opioid use disorder in outpatient settings. As you may know, with your interest in attending today, there has been this requirement for physicians to attend an 8-hour training and to obtain a separate DEA waiver in order to prescribe buprenorphine in these situations. And it's an effective agent. When compared head-to-head with methadone, we see similar rates of abstinence from illicit opioids, decreases in craving, and a number of the other outcomes to which I've already alluded. And the promise it carries, obviously, is methadone needs to be supervised and dispensed out of federally and state licensed opioid treatment programs, where this statutory modification allows for provision of a highly effective agonist therapy in settings outside of those specialist settings. And so why is this the case, and why is overdose potential lower with buprenorphine? I already alluded to this, the fact that buprenorphine is a partial opioid agonist, so it stimulates the mu-opioid receptor, but not to the extent that full opioids such as methadone or heroin do. Also has very, very high affinity for that mu-opioid receptor, meaning that it will displace your other typical full opioid agonists, and also has this ceiling effect that you can see, where with increasing doses of your usual opioids, risks for respiratory depression and death continue going up, 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 but where there's this ceiling effect for buprenorphine, where that risk is quite low when it's used by an adult as prescribed and not combined with other potentially sedating substances with which it could interact. So what's the deal with the new guidance? I made mention of the fact that 8 hours of additional training were required for physicians in order to obtain this X waiver That number for mid-level or APPs is 24 hours. But with this new guidance issued formally in April of this year, 30 or less patients can be treated without completing the training. Now, you still need to do a process, albeit briefer, to get that X waiver by way of submitting a notice of intent to prescribe. And I'm gonna see if I can just call up the website so you see what it looks like here. And this will be the same site that you'd see if you completed the data waiver training, but it can be completed much more efficiently. There is still a process. Again, you'll still end up getting a data waiver after you complete this, and that can take about 2 weeks, after which you could receive an email notification that is active. This new announcement allows for this practice without the 8 hours of training and treating up to 30 patients. If there's a desire to go beyond that to the 100 patient limit, the X waiver training, 8 hours for physicians, 24 for APPs, still needs to be completed. Other sort of portions that this announcement called out around which there appeared to be some misconceptions is, number one, referral to or providing psychosocial services on site isn't a requirement. So you'll need to be able to accurately state that you have the capacity to refer to some form of behavioral treatment services, which can be broadly interpreted, but there isn't language indicating that there is a requirement to do so for all comers. So there is some flexibility there based on clinical judgment, though definitely should be considering that, for the appropriate patients. And the requirements for the 100 patient limit, you see here, fairly similar to what has been there historically. That training still does need to be completed to apply to get the 100 patient limit. And then in addition to that, the practice needs to have some characteristics to it. The provider either needs to be board certified in a particular specialty, or the provider needs to be located in a, quote, qualified practice setting, which most, general primary care, general psychiatry practices will have access to. That there's, sorry, I know you guys are seeing the presenter view. I hear from Kathleen and Matt, but I think we're all right with that. So there should be some form of coverage for emergencies when off hours, access in some way to case management services, using health information technology systems, need to be registered for the prescription drug monitoring program, and should be a practice that accepts third-party payment for providing their services. I mentioned that the availability of behavioral health services and treatment is quite broadly framed. And when the different sorts of modalities are compared head to head, they perform pretty well equally. So you certainly want to consider comorbid mental health conditions and whether that resource can address those as well. But you don't need to be alarmed if you don't, say, have immediate access to CBT or DBT specifically, or something along those lines. Just a couple things around practice where I think I've heard from providers some questions or concerns about continuing to follow patients in lapse or relapse. This is going to be a fairly common one where it's often an expected part of the natural history of recovery. It may vary in severity, and certainly requires reevaluation of the patient and reevaluation of the resources and level of care that they might need. But guidance from professional organizations, including ASAM and SAMHSA, recommends that we don't jump immediately to, quote, firing or terminating a patient under those conditions, but rather think about circumstances through which we might be able to intensify a treatment plan, or monitoring if we feel like that's required. But just given the serious nature and mortality risk for the condition, there really is this encouragement to continue working with the individual. So far as urine testing, detecting diversion, there is a recommendation around this being part of the practice. There is some latitude around the frequency with which this takes place. Ideally, should include testing for buprenorphine and its metabolite. If available, testing for naloxone, since that shouldn't be present in urine at super high levels unless the urine is being tampered with, such as dipping a film into the sample. And with challenges around ongoing use or suspicion of diversion, again, there's some strategies that we can put in place to improve sort of monitoring and the data that we're getting by way of how well the plan is working in terms of considering more truly random visits for urine testing and medication counts if there's some concerns along those lines. And again, making sure to check the PDMP with each order. So far as diversion goes in the United States anyway, when Suboxone is taken illicitly, it's much less frequent for that to be getting taken to achieve euphoria, or that's the individual's primary drug of choice. Much more commonly used to self-treat withdrawal and sometimes to attempt to enter recovery, taper off. But something to have an eye to, particularly, if you have some patients that are on higher doses where patients may try to start tapering down and be able to use medication supply for other purposes. So just something to have in mind and do your due diligence if issues are starting to come up by way of early fill requests and concerning urine tests, things along those lines, and providing that education. The other thing this practice gives us opportunity to do, of course, or engage in other aspects of health promotion for individuals struggling with opioid use and ensuring their more global health, particularly early in recovery, where again, there may be more lapses and reconnections to care, ensuring safer injection techniques and safer supplies for individuals who are injecting. Providing education and prevention around overdose, making sure this is a population that has naloxone in hand, which can either be prescribed or syringe service programs in our state also provide naloxone and the training in using it, as do public health departments and some local, more commonly community and some pharmacies. Ensuring appropriate testing for bloodborne viruses and sexually transmitted infections and appropriate vaccines, particularly hepatitis A and hepatitis B for individuals who are at risk for hepatitis C due to the increased morbidity with that combination. And also always encourage folks to have an eye to what's happening in the individual's life by way of supervision or criminal justice involvement, since that's so common and they may be at risk for incarceration that requires some discussion and care coordination around plans for their buprenorphine if they were to enter jail, as a number of jails and counties in Wisconsin will not continue that. So if I'm assuming there are some of you that have not yet engaged in this practice, or maybe you're just starting and wondering about some resources to support you as you're going forward, we have our monthly ECHO sessions where we present and discuss cases involving substance-related issues and also have didactic content. These are on the third Friday of every month, starting at 12:15 as well. So, and we'd love to see you there and hear about your practice as that moves forward and come together with experts as well as other providers in the community to talk about challenges that you might be having or questions you might have. You can also call the Access Center, UW, and you can see the number up there and ask for the addiction medicine provider on call if you have a question about a patient in front of you in the office. and we can provide you with some assistance over the phone around that patient care. A couple other things that we'll be having coming up, if you're interested in learning more and getting the full data waiver training, we do have a session coming up September 30th that will get you the X waiver and also can lead to that increased cap for your patient practice. And then as we've gone through that, we've found a lot of providers who complete the data waiver training feel like, man, you know, I could use just a little more to figure out how to really launch this in my practice. And we do a series of boot camps around use disorder management in generalist settings. And we have one planned for October 22nd this year that we will continue to be offering virtually. And I believe Kathleen put up some information and links to those information on those upcoming sessions in the chat. So hope to see some of you there. And we'll be sure to get you this information in a way that you can access it. These are some nice and fairly efficient resources to get through by way of the guidelines that I was just addressing around the new guidance by way of obtaining an X waiver. I made mention of some local supports here. If you'd want to reach out or participate in those as you're gearing up or increasing your involvement in this practice, but the Substance Abuse and Mental Health Services Administration also sponsors a provider clinical support system that can gain you access to a mentor, and they also have a variety of educational resources on the site as well. If you're practicing in a location where you haven't yet developed familiarity with the treatment resources that are available, SAMHSA has a treatment locator on their website that you see here that you can search by way of zip code or municipality and get some information. Though being a federal database, it might not be quite as up to date as contacting your county's Department of Human Services. And so far as advice that's patient-facing, Wisconsin 211 is a resource that patients and families can get to via the phone or online if they have questions about the resources they can access for a loved one in their community. So I have already talked longer than I was sort of hoping to. I was hoping to save a bit more time for conversation, but we'll move to that. And I've got my email up here too if any questions come up that we don't have time to get to in our remaining time. Oh no, actually I did pretty good. I was thinking we started at noon, but we did start at 12:15. That wasn't so bad. Hope it wasn't so bad for you either.